Good afternoon, all. Thank you so much for joining us. My name is Christine Monahan, and I'm an assistant research professor at the Center on Health Insurance Reforms. I am excited to kick off the second installment in our series of webinars on advancing diabetes coverage and access in the private health insurance market. Today, we have three speakers to help us understand how prior authorization affects patients living with insulin-requiring diabetes and the policy options for reform. For those of you who are new to the Center on Health Insurance Reforms, we are a nationally recognized team of health insurance experts within Georgetown University's McCourt School of Public Policy. We conduct legal and policy research and analysis, publish reports, and provide technical assistance to stakeholders and policymakers across the country, both at the federal and state levels. We have teamed up with the Leona M. and Harry B. Helmsley Charitable Trust to apply our passion for private health insurance to better understand the issues facing patients with diabetes who require insulin and the reforms that could improve coverage for them. To that end, today we are excited to share with you some of our findings and let you hear directly from some of the amazing people with real-world personal, advocacy, and policy-making experiences whom we've had the benefit to learn from. Before we get started, I need to cover a few housekeeping matters. First, we will be recording this and we'll share a link after the call. If you like what you hear today, please share the recording with others in your network to get the word out. Second, we'll be posting links to key resources in the chat during the discussion. To the extent you have any technical issues or general comments or feedback, you can feel free to put them there as well. If you have questions for our speakers, however, please submit those by clicking the Q&A button at the bottom of your screen and typing them in there. We have reserved time at the end to answer audience questions. Feel free to add questions as we go. Our team will be monitoring things throughout the webinar. And finally, I'd like to announce our speakers. Kicking us off will be Chair Assistant Research Professor Amy Killalay. Amy has been leading our research and writing on diabetes coverage for much of the past year and brings more than 15 years of experience in public health law and policy with a focus on medication access and affordability. Today, Amy will be offering some background information on prior authorization and sharing some advanced findings from an issue brief that we'll be publishing in the coming weeks. Following Amy, you will have the pleasure of hearing from Christina Choate, Advocacy Chair and Board Member, Breakthrough T1D Mountain West Chapter. Christina is based in Utah and will share her own personal experiences and what she's learned as an advocate for patients with type 1 diabetes. Last but not least, we are excited to welcome Kyle Brown, a member of the Colorado House of Representatives and former state insurance regulator. Kyle will tell us about his experience working in prior authorization reform legislation this past year in Colorado. And now, without further ado, I'll turn it over to Amy to get us started.
Terrific. Thanks so much, Christine, and hi, everybody. I'm going to pull up a few slides for us. Give me one moment. All right. So I'm very pleased to be with you speaking about this topic. There's a lot to cover, and so my role is really to set up the speakers and give you a bit of context to really engage with the prior authorization topic, which is one that is near and dear to many hearts for various reasons. As Christine said, this work that Georgetown is engaged on is supported by the Helmsley Charitable Trust, and this webinar is part of a webinar series and a larger body of work that Georgetown has been engaged on across these many months, and really at the heart of it, focusing on policy considerations that increase access to and affordability for the range of services that folks with insulin-requiring diabetes need to stay healthy. And when we say insulin-requiring diabetes, we are referring to type 1 and type 2 diabetes, but for folks who need insulin to stay healthy. So the research that we've conducted so far, and then I'm going to give you a little bit of a preview as to some of our findings today, included an extensive environmental scan, informant interviews across different perspectives, state policymakers, state insurance regulators, patient advocates, and providers. And we focused our research on 6 study states, the states and jurisdictions that you see in front of you, to really get a good cross-section of how states are approaching the challenges of increasing access to diabetes services and coverage. And as a preview as well, I'm gonna be talking about some of our findings, and you will be able to read all of the findings plus many more in a forthcoming issue brief to be released in the new year. So consider this, hopefully this will whet your appetite to learn more. And to ground us too, we sort of gave this caveat proviso at the beginning of the last webinar, and we'll do it again here. We are focused on the state regulated private insurance market. That is the market and the focus for the policies that will be highlighted in the issue brief. That's what I'm going to focus on in my sort of context setting remarks. And when we say state regulated private insurance, this chart kind of gives you the everything you wanted to know and maybe things you didn't want to know about that market. So we're talking about the individual market, on and off ACA marketplace plans, the fully insured small group and large group market in a state. And even within a state, those markets may be regulated slightly differently. But that's our focus for the issue brief and for the prior authorization pieces that I'm going to talk about. And last time we focused on the two columns on the left. So these are the three big focus areas for our first issue brief to be released in the new year. We looked at coverage requirements, we looked at cost sharing protections, how to make diabetes services more affordable for folks in the private insurance market. And then this third bucket, which we're going to be talking about today, utilization management, and in there really focused on prior authorization in particular. And in some ways, this, the order that we're talking about this is very intentional. We've kind of, you can look at coverage and coverage mandates and you can see, okay, insulin is covered, CGMs are covered, a whole host of different services that people with insulin requiring diabetes need. But that's only one part of the story. And so this webinar is really getting at the second part of the story, which even if a service or item is covered, what are some of the limitations that a private insurance plan might put on that service? And what are some of the ways that we can make sure those limitations don't get in the way of clinically indicated, clinically needed care? So a very quick overview of what we're going to be talking about. So prior authorization, what is it? How does it work? I think the first thing to remember about prior authorization is that it's a limitation plans place on a service after it's already covered. And so I'm distinguishing this from a coverage exclusion. So when something's not covered at all, you might be able to appeal to get it covered, but that is a different animal. We are talking about services, medications that are covered by the plan, and prior authorization is a way for the plan to require a provider to basically justify why a patient needs access to this particular service, this particular device, this particular insulin product. And so the prior authorization, when you see the little PA sign next to a medication, device, or service, that means that in order for the plan to pay for it, a provider is going to have to submit documentation to the plan telling the insurance plan, why do you need this CGM over another CGM? Why do you need this insulin over another type of insulin? And that will go to the plan, and then a plan is going to rule yay or nay. They're going to say, yes, you know what, we agree, you met all our criteria, this is approved, go forth and get it, and the plan will pay for it. Or they're going to say, no, you didn't meet all the criteria, it's not approved, in which case that patient will either go to a different device, medication, or they will appeal the decision, and that could take time. But this is sort of how it works at a very high level. And in our research, not surprisingly, and whenever we talk about prior authorization, the reaction from folks is usually fairly visceral. It really does show up in the day-to-day sort of real life experiences of people who are trying to access services and providers who are trying to prescribe services. And I think the overarching theme that we heard when we talked to particularly patient advocates and providers talking about how prior authorization impacts diabetes care is this first bullet, that prior authorization and the criteria and hoops that folks need to jump through are not necessarily aligned with diabetes clinical standards. And so what I mean by that is that you've got a limitation that a plan is using, and it is a limitation that might be getting in the way of access to the clinically recommended product for the person, right? So, non-clinical switching of insulin is a good example of this, right? Where you've got a clinically indicated need and prescriber decision to prescribe a certain insulin, and then you've got a prior authorization that might dictate going to a different type of insulin for a sort of non-clinical reason. And so that's sort of like the overarching challenge. And what that leads to is really time-consuming and resource-intensive approaches to get prior authorization, to get sort of over those hurdles. So providers talked about this at length, sort of the time and energy it takes to appeal a prior authorization denial, to make the first prior authorization request, administrative headaches to reapprove access. So you've got a prior authorization that's approved, but it expires. But as people, particularly with type 1 diabetes, know, like your diabetes does not expire. And so the sort of headaches to reapprove already approved medication or other service needs. And then denials. Again, denials of prior authorization, those appeals, even for a denial, take time, and they can lead to interruptions in care. And so, I think the real interesting part, right, is like, okay, we know that there are challenges in this area, but how are state policymakers addressing them? And, very excited to hear from Kyle and what Colorado has done in this area. And really, there's lots of different options, and we see the different types of reforms for prior authorization sort of take a continuum where you really do not have any state that's moving in the direction of prior authorization is prohibited in every single instance. We don't have any prior authorization anymore. But if we see that as one pole, right, and the other pole is we have no restrictions on use of prior authorization, states are coming out anywhere in this middle area, right? There's some process protections, increased transparency, protections aimed at providers, make it easier for a certain subset of providers to get prior authorizations through. And we've got, moving along to more substantive protections, really requiring PAs to be based on clinical guidelines, requiring clinicians with expertise in the particular service, medication or device to be making the prior authorization decision for the plan. And then from the sort of getting closer to prohibitions, not prohibiting all PA, but saying, okay, there are some medications, there are some conditions where we think PA is more trouble than it's worth, and the state, for at least some segment of the market, is going to say, you can't have PA for that particular condition, that particular medication. And we saw this play out in the 6 study states. So this is like a quick chart, and we'll send these slides afterwards. So I'm not going to go through all of these in detail right now, but you can see that across these different categories, states varied, right? The requirement of medical expertise to review a PA request, tethering a PA to evidence-based treatment guidelines, looking at the provider and really making it easier at a provider level to get prior authorizations through. So, it runs the gamut, and I think this is an area where we're going to continue to see movement. So that I hopefully kind of sets up our 2 speakers to talk a little bit more granularly about what this looks like on the ground from a policy perspective and from a patient advocate perspective. I mentioned the issue brief where we're going to talk in more detail about our findings on this area and the coverage and affordability areas. You've got a QR code there. If you're not already on our list, please sign up through the QR code and you'll be the first to get the issue brief in your inboxes. And then we also have the 3rd in this webinar series coming up on January 23rd. And we'll put a link to register for that webinar in the chat as well. So with that, I will turn it back to you, Christine.
Thanks so much, Amy. And now we have the opportunity to speak with Christina Choate. Christina, to start things off, I was hoping if you can tell us a bit about yourself and your experiences advocating on behalf of other patients with type 1 diabetes.
Yeah, thank you, Christine, and to the team at Georgetown University for hosting this series. Going to be an awesome series here, and I'm grateful to be part of today's session on prior authorizations. My name is Christina Choate, and I live just north of Salt Lake City and serve as the advocacy chair and board member for Breakthrough T1D here in Utah. I've lived with type 1 diabetes for 21 years. My father lived with T1D for just over 40 years. And I'm really passionate about engaging with the diabetes community on advocacy efforts, health policy, and research related to this quite honestly less than desirable condition. I meet with our US senators and representatives in Utah and DC to educate them on, and their staff on what it's like to live with this condition, especially insulin-required diabetes in this case, and the challenges we face and the ways our community wants to work together with the federal government to make a difference. How are we going to get to cures? I work with all ages of folks living with diabetes. I meet with families that have just been diagnosed within the last month and families who have been living with type 1 diabetes way longer than I have. Today, I'm going to speak from my own personal perspective as someone who lives with type 1 diabetes and my own experiences with prior authorizations, and share a couple of stories from T1D friends here in Utah who have experienced similar challenges.
Great. We really appreciate your personal insights. To start, could you walk us through a specific experience you've had with prior authorization for diabetes-related care and any obstacles that you faced?
You bet. The most common obstacles I face regarding prior auths for my diabetes care have been choice and delay, really due to the paperwork and the processing time. For many of us with private insurance, our insurance companies have chosen for us which insulins are preferred. That's to encourage the use of cost-effective insulins over these non-preferred insulins. If my healthcare provider prescribes a preferred insulin, I'm likely not going to have any issues as I go up to the counter outside of the out-of-pocket cost. But if an insulin's not on that preferred drug list, many of which are not, then I'll have to go through the prior authorization process to even get a chance at filling it. And in some cases here in Utah, I have to try a preferred insulin or other drug before the request for the non-preferred drug can even be made. So process takes time. It's taking weeks, sometimes months. The paperwork from your healthcare provider's office can be a headache. For those of us with insulin-required diabetes, insulin's non-negotiable, keeps us alive, it's required. So the delay in access to the insulins that our doctors are prescribing us is more than frustrating.
In your experience, in addition to insulin, are there other services or supplies that prior authorization tends to apply to?
Absolutely. Yeah. Prior authorizations tend to apply to insulins, but also insulin pumps, continuous glucose monitors, and I believe are more likely for newer drugs and devices that have recently come to market, the things that we're really excited about in the T1D community. In addition to insulin type, it can also apply to how it's packaged, to be honest. Pre-filled pens can trigger the prior authorization process as well. That was the case for me in terms of long-acting insulin that was prescribed as a backup to my insulin pump should it ever break down. It can also apply to your diabetes pharmacy, so where you're going to fill your durable medical equipment, and supplies such as continuous glucose monitors and insulin pumps, some of those third-party places that are going to dispense the supplies you need on a monthly basis. But really, for myself, prior authorizations can impact all aspects of my diabetes care except for choosing my physician and buying a glucose monitor at the pharmacy to prick my finger. That's about where I draws the line.
That's a lot. Lots to have
Yeah,
to go through for every aspect of a very complicated disease to manage.
right.
And so have there been instances where delays due to prior authorization resulted in adverse health outcomes in your experience or for others you know in the diabetes community?
Yeah, unfortunately, Christine. So here in Utah, a 15-year-old girl was just recently diagnosed with type 1 diabetes. And in the hospital, she learned that she could start on an automated insulin pump soon, which is wonderful. A lot of us in the type 1 diabetes community really benefit from this technology. It's a closed loop system. After she would have additional diabetes training and self-management of her new diagnosis. The disease is completely new to her, no family connection in her family. And as a 15-year-old in high school with a new driver's permit, she's got a lot on her plate and a lot to learn about T1D coming up. So as the end of the year approaches here, we're in December, she felt rushed to choose an insulin pump due to the prior authorization process. So having little experience with this disease up until recently and having to choose a device that she's going to wear 24/7 for the next 4 years as a requirement of her insurance, it can lead to rushed decisions, clearly both for the patient and the healthcare providers having to do all this paperwork. In addition, with my own personal experience, prior authorization requirements have sometimes leading me to choose the easier road in my diabetes care. For example, if a new insulin or a diabetes device is going to require a prior authorization, something that's shown benefit to the community for insulin requiring diabetes, I may not choose to go down that road, and I have chosen not to go down that road before because of the headache and paper chasing that's required living with insulin required diabetes, whether it's type 1 diabetes or type 2 diabetes in that case. It requires constant vigilance, constant self-management, a lot of work up here, and anything that adds to our plate has the potential to lead to adverse outcomes.
So do you have steps other than just saying like, well, I'm not going to get the best care that I really need? Are there other steps you typically take when faced with a prior authorization denial or delay to try to manage or get through?
Yes, I lean on my healthcare provider team, which has been wonderful. I do have a wonderful team that has many resources that I can lean on, whether it be within diabetes education or other resources that can walk me through those processes. A lot of them are required to stay up to date on the latest technologies and the latest requirements in order to be efficient in their offices. There are many patients within these endocrinology offices, so we got to move fast, but I do really lean heavily on my healthcare team, who can walk me through what they've experienced with other patients with diabetes.
Thank you so much, Christina. I'm really looking to
Thank you.
forward to hearing more from you when we return to the audience Q&A. For now, we're going to move to our last speaker, Kyle Brown. Kyle, to start things off, I was hoping, could you describe how Colorado has recently reformed the state's prior authorization laws and let us know when those changes go into effect?
Yeah. First of all, thank you, Christine. As you mentioned, I'm Kyle Brown. I'm a state representative here in Colorado. We have been working on prior authorization at the legislature for a number of years. And, there have been a lot of conversations with patients as well as with provider groups that, you know, um, try to deal with the necessity in some ways of having some level of prior authorization, but also making the process work much better for patients and providers. I think Christina's examples and experience here are particularly poignant because when prior authorization kind of gets away from us, it becomes unmanageable for patients and it becomes a real barrier to care. So there have been a number of proposals over the last several years in Colorado. We finally got one across the finish line here in just the last session. House Bill 24-1149 was a bill that made significant changes to prior authorizations in the fully insured or state regulated space of insurance. Specifically, it made, while it wasn't specific to diabetes, it made specific changes to the way that medications for chronic conditions can be, prior authorization can be requested for. I think the most significant was that for a carrier or a PBM is prohibited from imposing prior authorization requirements more than once every 3 years for a chronic maintenance drug. So, instead of having to go through the prior authorization every 6 months, every time you get a new prescription, you now can, go through that once every 3 years. Another thing that we did is to make sure that a prior authorization, once you go through it, that specific approval extends longer than it used to. So Colorado law used to allow for 180 days for that approval to apply. It now extends for an entire year. So if a healthcare service or a particular prescription is authorized, that authorization is good for a year. We did specific things to allow for providers who are requesting prior authorization in keeping with the evidence, the national evidence-based standards that we should be relying upon, and generally getting approved. We require insurance companies to create a qualified provider program so that these qualified providers have a more streamlined approach to their to receiving prior authorizations and to dealing with prior authorizations. And it's based on an evaluation of those qualified providers and how they are requesting prior approvals, and then receiving them. We also help to make sure that there is a uniform dispute resolution process, so that if there are prior approvals that are being denied, that providers they have recourse. They can request arbitration in some cases, and that provides an additional sort of safety valve or release valve, if you will, for some of the conflicts throughout the process. I think it's also important to notice that in the bill, we built in a significant amount of transparency. There's a kind of a lot of confusion and concern because to a lot of degrees, prior authorization can be kind of a black box. You submit something into a void and the insurance company either accepts it or denies it, but you don't really know why necessarily. And so the bill requires insurance companies to make data about their prior authorization requests, denials, appeals, public and public facing on their websites. It also requires the insurance companies to eliminate prior authorization requirements, to continually review and to eliminate prior authorization requirements that don't promote quality and equity in our healthcare. So with that, I'll stop and just say that I think that what Colorado did is to try to strike the right balance between a tool that can be useful for confirming diagnoses, potentially controlling unnecessary utilization, but also trying to make it much more friendly for providers and patients, so that care and access are available. So I'll just appreciate the opportunity to kind of share with you what Colorado has done and how we've approached the issue.
Thank you for that. And I think it really shows how multifaceted the issue is, right? Colorado's law is just like tackling just one aspect of health insurance from so many different angles. It's a really kind of like nuanced issue, and Colorado's law is, relatively comprehensive. I'm curious, like in tackling on this, big topic, were there specific cases or data that highlighted the need for change that really kind of motivated lawmakers in Colorado like yourself?
I think that, we didn't have specific data necessarily about prior authorization approvals like that. That was part of the aspect of the bill, was like, we need more information to know how this is working. But I do know that we heard a lot of stories from patients like Christina, who had faced this. And particularly, I think it's hard to argue that a person who, has a chronic condition, a condition that they're going to live with for the rest of their life, that somehow a 6-month prior authorization renewal process was going to be necessary, right? Nothing has changed about that person's condition in the past 6 months. While there is certainly, some value in checking in periodically, it makes a lot more sense, I think, to do it on a less frequent basis when you're talking about something that is just a part of the person's everyday life. So I think that was particularly salient to me in thinking about why we would extend require carriers to basically honor a prior authorization for extended periods of time.
Absolutely. And I think that really kind of gets to the question I was going to ask next, which is one of the ways, how does Colorado's prior authorization reform help people with diabetes in particular? And I think you just gave a great example where it's a chronic condition there. We don't need to keep checking that this person needs the same medication, insulin, same device every 6 months. Are there any other aspects of the law that you draw out as really relevant for this community?
I think I'm certain that with like for the diabetes, for folks who are living with diabetes, right? They have their primary care providers. Certain providers are going to be working with a larger number of type 1 diabetes patient or insulin requiring diabetes patients, I should say. And for those providers going through the same kind of hamster wheel requirements of prior authorization can be particularly onerous. So making sure that the requirements are as streamlined as they can be to free up that provider for patient care and help to improve access. And that, I think, obviously helps to improve access for people. That's important, right? Again, balancing the need for having prior authorizations to some degree with access, and sort of when prior authorization becomes a problem, it's when it's prior authorization for prior authorization's sake, right? And that doesn't strike me as terribly effective.
And could you describe the process of developing the law, and in particular, to what extent patients, payers, providers were involved in shaping the bill that was passed?
Yeah, that's a good question. So it was a very complicated and complex stakeholder process led by two of my colleagues, a bipartisan coalition of folks. Uh, Patients and providers were certainly at the forefront, and the payer community, I think, struggled with further restricting their ability to use prior authorization. There were certainly concerns about increasing costs, but on the other side, of course, there were concerns about some of the onerous requirements, some of the requirements that didn't seem to make anybody any healthier or improve quality or promote better outcomes. It was so finding that right balance, but providers, payers, patients were all at the table in crafting the final outcomes.
Great. And then maybe stepping back a little bit, aside from prior authorization, could you speak to some other policy areas related to utilization management, say medical necessity definitions, step
Mm-hmm.
therapy requirements that, states like Colorado are looking at and have authority to kind of regulate or potentially improve?
Yeah, we've had a number of bills over the last several years that have looked at utilization management practices, in particular for chronic mental health conditions. We have often looked at the need for particular for prior authorization or step therapy. Step therapy continues to be particularly uh, important topic, and in mental health care, in oncology, we have done things to put certain requirements and guardrails around when step therapy can be utilized, and when it can't be. I think, will continue to, in Colorado, a bill that I will be bringing this year will continue to look at what is an appropriate definition of medical necessity, and how does it line up with national standards in this area. There's a lot of concern that insurance companies develop their own criteria for what is medically necessary in any given circumstance, and and don't necessarily utilize nationally accepted criteria, especially in mental health. And states like Maryland and Illinois have taken the lead on this, making sure that we have established definitions of medical necessity and making sure that standards, nationally accepted standards, are being applied in all cases. So that'll be something we'll be visiting here in Colorado as well.
We look forward to seeing what you do. Kyle,
Yeah,
thank you so much for sharing your expertise with all of us. And with
of
thanks
course.
again to Amy and Christina as well. I'd now like to open up the floor for audience Q&A. And so if you haven't already done so, please submit any questions you have using the Q&A box at the bottom of your screen. And to kick things off, I do see a question that I think everyone here on this panel can answer and give a different perspective on. And that's, what is the best way on the ground that clinicians can help move forward policies like we've seen enacted in Colorado? And maybe I'll start with Christina, actually, to see from your, position, in an advocacy role, how are you working with the provider community?
Oh, it's such a great question. I think that it's really important to have these voices at the table, in addition to the patient voices that I'm talking about today. So um, I'm trying to see what her name is here. That is it, Catherine? Catherine, I'm so glad you brought this question up. I do believe that these voices talking to our lawmakers is just as important as the patient voice, because they do have a perspective on what the paperwork looks like from their end, what barriers they're seeing with multiple patients, not just one patient, like from my perspective, and what barriers they have in terms of being able to educate patients on what they need to know about these drugs. So I think that getting involved in advocacy organizations within the diabetes community is super important. Really using your voice to share your story can make a difference. It can bring about legislation or just making sure that the right voices are at the table. So I would suggest being a part of an advocacy organization that is talking about these things, engaging in webinars like this so that we can really get to the root of what some of these problems are. And meeting with folks like Kyle, who are willing to hear about the issues and come up with solutions. So I'm glad that question came up.
Kyle or Amy, do you have anything to add about what you see the role that clinicians can play in advocacy?
I think I think Christina said it very eloquently. I think the only thing I would add that I think providers have a really unique voice is to really make that to tie the requirements for access and payment for a particular service to a clinical standard. I think that's patient advocates have a voice and healthcare advocates have a voice, but providers are sort of uniquely situated to be able to, with high credibility, talk about the standard of care and what is necessary to make sure that someone with diabetes stays healthy. And so I think really sort of deploying that expertise and talking through how a prior authorization requirement, how specific criteria either is or is not aligned with clinical standards. I think that's really, really powerful. And then just like a very practical piece as well, the diabetes patient advocacy community is strong and deep. And we certainly are familiar with. You mentioned Breakthrough T1D, and the American Diabetes Association has many state affiliates who are doing lots of work on the ground. So that is in each state. So that's sort of another very practical group to affiliate with at the state level.
Right. Well, then I might combine kind of two questions that I've seen come through in the chat that I think are related. One is kind of broadly asking about, what sort of research is going on or could be done to see kind of the value add of these requirements? What effect is it having? And so I'm curious, Kyle, whether, Colorado has a plan to kind of evaluate this, or if anyone else has thoughts on kind of how do you see, is this making a difference? And then to kind of add the second question in there, in particular, will you be looking at, and should people be looking at the effects that this has on inequities and disparities, knowing that a high proportion of the population with diabetes comes from Black communities, and so are we looking at that?
Yeah, that's a very good question, Christine. Parts of this law go into effect immediately, and parts of the law is specifically the parts about sort of the qualified provider program go into effect about a year from now. So we're still very much and immediately, I mean, back in August. Colorado laws typically take effect right around the beginning of August after our session ends. Um, and so I think that now is really a good time for researchers to be evaluating this information. Unfortunately, what you don't have is a baseline, right? We require a whole bunch of data now to be placed on websites and things, but you didn't necessarily know what things will look like prior to some of these laws. So getting some of that data may be challenging, but I would that's a challenge that I place at the feet of the research community. So I do think there will be some information out there that can be utilized to talk about the effectiveness of these policies.
I would echo all of that, and I would just add too that I think research is important, and I think it's important to be really intentional to measure the sort of direct and then the more indirect consequences of action. So, for instance, I would be curious it's to states who have taken a harder line on prior authorization reform, what the effect on exclusions, because there's no, unless you have a sort of corollary requirement that a plan cover everything, then a really hard line prior authorization requirement could have the unintended consequence of pushing the medication or the device off the formulary altogether. So like that would be one thing I would be interested in, are there unintended consequences? And then in terms of like really getting a sense of like the before and after, the person in the chat noted in very important detail that there are also these like prior authorization can cause kind of pre-decisions that move people away from certain products. And research is not going to catch that, right? If you're just looking at what are the prior authorization denials, right? And you just look at denial data, you will only get a sliver of the impact because you're not looking at how did the prior authorization impact provider prescribing behavior. And so I think, pairing any type of data-driven analysis that's looking at claims data and looking at outcomes and utilization and impacts there, I think really should be paired with more qualitative data on how does prior authorization impact how providers operate, and how patients make decisions, and I think those are all will help to kind of give a more comprehensive story as to the impact, and we'll learn, right? I think we're still at the kind of early days of extensive prior authorization reform. And that's how reform works. We kind of learn, all right, well, we went a little too wide on this, and the next state learns from that and refines. So I think that's all sort of part of the process when you're starting to do something new in health policy.
Well, and to that end, I think that also prompts another question we got in the chat about, is this going to be a 50 state, one state by one state by one state enacting these reforms, or is there any, effort potential for action at the federal level? And I will say our webinar at the end of January, that is something we are planning and hoping to cover, is kind of what's coming down the pike for 2025. But if any of our panelists would like to opine or is hearing anything that you want to share now, just throw it out there.
The only thing that I'll say is that as states, we are limited in the markets that we can regulate. So while we can regulate this individual, the small group, and the large group fully insured markets, ERISA plans are off limits for us in general. Now, if the federal government wanted to give us jurisdiction over ERISA plans, I'm sure we would take it. But the federal government, in order to really fix some of these problems, especially for your self-funded employers, and keep in mind that in Colorado, the commercial market is about 2/3 self-funded plans. Uh, that that's that's a significant amount of people that these protections potentially don't apply to. Now, maybe insurance companies will change the way that they do business because we're making a portion of their business do it. But I think we do need some action from the federal government on, just like we needed action from them on surprise billing. We need action from them on prior authorization reforms. in order for them to apply to the broader market.
Yeah, and for those of you joining us who are not insurance wonks, right? So the self-funded market, those are employer plans, generally mid to large size employers who are kind of taking on the financial risk of insurance themselves. And so they're paying out the claims out of kind of a fund that their own funds. What will often not be clear to you as a patient, as a consumer, is whether your employer plan is self-funded or not, because often the employer is going to hire a big name insurance company to administer their benefits for you, to use their network. And so that's something that can be hard to kind of navigate. Like you're hearing about, okay, these prior authorization protections apply to Colorado. You may not necessarily always know kind of, does that apply to your plan or not? And it kind of turns on, whether it's fully insured, where you're buying a policy from an insurance company, or whether it's self-insured. And so that's just, if you're encountering issues, it might be a question you need to ask your HR, your employer, so then you can figure out, okay, like who do I go to? What resources are available? What laws apply? And actually, I have a question for Christina too that came up. And, again, for taking that like patient perspective, are there any tools that you think would be helpful for patients who are facing prior authorization challenges? Are there any resources or organizations you've seen out there who are helpful in navigating these issues in addition to your provider team?
Yeah, that's a great question, Christine. I think for some of us with insulin requiring deep diabetes for so many years, we have our own little tools and tricks that we've collected along the way, put in our pocket and run with. But I would say some of the more formal resources out there, I do know of a insurance toolkit that Breakthrough T1D has put out there. I can try to link to that. I also believe that there may be one or two of my Breakthrough T1D friends on the call that could maybe help out, but I'm going to try to link to that insurance toolkit that the team has put out there. Like I said earlier, I also really do lean heavy on the healthcare team, just because they are working with so many patients that they've learned along the way. I don't know if that's the right way to do that, right? But these providers and their staff, often the staff working along on the paperwork and working with the reps and working with these vendors who are supplying the diabetes supplies, they themselves are learning tricks along the way, and not necessarily finding workarounds, but just learning the best ways to be efficient to get you what you need. So I would recommend leaning heavy on your healthcare team. Now, for those of you who are on the call who are that healthcare team, I just want to say thank you from a patient perspective. You guys really, for all of us who have insulin requiring diabetes that are managing it 24/7, you are our go-to when we're at lows and when we are frustrated with our insurance and when we are frustrated trying to figure out what's required. So I just want to call out the people on the call who are in those positions. Thank you for supporting us. And if there's anything that from a patient perspective that we can be doing to better represent our healthcare team while we're out, please share that in the chat. I would love to be a great representative of those folks as well while I'm out. Christina, I hope that that's an okay answer there. I'm going to link to the health to the insurance toolkit, and I hope that that's at least a start.
That's super helpful. Thank you. I have another question, maybe start with Amy on this one, and that's, whether, should chronic conditions like diabetes be treated differently under prior authorization policy? I think we talked a little bit, right, Colorado's law, it's not talking about diabetes in particular, but there are on kind of the chart that we briefly had up on one of those slides, there are some conditions that have been called out in state prior authorization laws and other circumstances. And so what are the pros and cons of creating, disease or condition specific prior authorization rules?
Yeah, it's such a good question, and there's not an easy answer to it. I think on the side of sort of carving out disease specific or condition specific or service specific protections in prior authorization and other spaces. I mean, we see that in other insurance spaces too. The arguments for that is that, you kind of you look for conditions that you sort of are going to see the most potential discriminatory plan design. Sometimes that's a criteria, or conditions for which prior authorization has the biggest potential to be a barrier to access to needed care. So, the examples that we found in the 6 study states were HIV and medication-assisted therapy for substance use disorder. So, you can kind of look in there, diabetes, you can make an argument there. You can say, people with type 1 diabetes should not have to jump through all these hoops. The stakes on the other side of getting it wrong, right? The stakes of getting prior authorization wrong are so high that we want to carve out specific protections for this community. There are arguments to be made there, right? And I think there's also this kind of political realism argument that, prior authorization is hard for most people. Like, I think there are ways that reform would benefit a lot of people, but you may have more political appetite to address a smaller subset. And I think that's probably driving some of the more condition-specific reforms in some states. So, that's kind of all the arguments of, like, you should look at it and there might be opportunities there. And then I think on the other side of it, you can say, you know what, prior authorization is big, and it's not just deployed on one set of medications or one disease, and it actually affects a great number of people. And so maybe your best bet from both a policy and, sort of an advocacy perspective is to join arms with as many affected people, patient groups as you can, and say, enough, like, this affects all of us. We all have a stake in reforming it. So I know that it's probably not a very satisfying answer, because it's very dependent on your sort of your state landscape, the coalitions you have in place. Do you have friendly legislators to go big, or are you in a position where, like, let's start small and then maybe build on it? I think too, like, the disease specific prior authorization reforms, in many ways, those can be a foothold to something bigger, right? You sort of try it out and then you see, like, did it work? Did it do the thing that we wanted it to do? And you can also say, look at your actuary data and say, did it break the bank, right? Did it actually hike up premiums, or did that not actually happen? And then you have data to kind of build off from. So there's pros and cons, and I think a lot of it has to do with sort of like the political reality that you're in state by state.
Amy, you hinted at kind of the cost question, right? I mean, insurers will say, prior authorization is a tool to contain healthcare costs and spending. And so, Kyle, I'm wondering if maybe you have anything else to add to kind of the kind of disease-specific or condition-specific question, but also too, how did Colorado think about kind of balancing cost considerations versus patient access and quality of care? And, how did that come up in Colorado?
Yeah, I think there were significant concerns from advocates, as well as from the Division of Insurance, the insurance companies, that restricting too heavy a hand on prior authorization was going to increase costs. It was going to lead to unnecessary or inappropriate utilization. And so, striking the right balance was important. And I will say that has been a function, I think, of previous laws. Like when we passed in 2023, we passed a law related to drugs for serious and persistent mental illnesses. And we required that we limited step therapy in those situations. Like a company couldn't require you to try more than one other drug, essentially, before giving you the one that your provider actually wanted you, right? So it's like a very small step, but these are the kinds of ways that we have tried to make the process, I think, work for the whole system, right? We can argue, I think, about the appropriateness of whether that was appropriate or not, and I do think that there is reasons to think that prior authorization has gone too far in many cases, and that's why we've passed the bills that we have. But there are, I think, legitimate concerns about increasing costs, and the ability of insurers to manage their costs. And so we will continue to sort of live in this tension between cost and access.
And now, one last question we had come in as we're coming up on the hour, and this it takes us back to our first webinar, and also I think again previews the one we're planning for January. And so I'll direct it to Amy. But we did have a question about just how important are insulin cost sharing caps for patients? What's the likelihood we'll see Congress enact a national standard in 2025? Can you reflect back on some of the information we shared on cost sharing?
Yeah, it's a good question. I think the short answer is very important. I think certainly preview for the issue brief, how they're designed matters, so that there are nuances to how you design a cost sharing cap in a way that is most impactful for people with insulin requiring diabetes. But short answer, yes, they matter. And in terms of a sort of federal national cap, I think there's a lot. A lot will play out in terms of how Congress will address healthcare in this sort of new Congress, new administration. That we've got a cap in Medicare, and I think in many ways that was anticipated to be the foothold, right? It's sort of you go with one market. Medicare is big, so goes Medicare, so goes a lot of other state and other markets, and so I think that's a good thing. And we should all anticipate that one day that might be the standard across payers. And I think my maybe more, I don't know, measured, I won't say skeptical, but measured assessment of whether we're going to see that in the new Congress and new administration, whether we're going to see, a federal law that governs a wider swath of the private insurance commercial markets and cap copays for insulin. I don't know. I think to be determined. I think there are a lot of other policies swirling about that are not that. So I think we'll have to see, is there appetite for sort of bipartisan approach to insulin access? And first we kind of have to get through, is there appetite for a non-bipartisan approach to healthcare access writ large, and what will that look like? So to be determined, but more in January, and maybe we'll have the answers by then. So stay tuned, January 23rd.
Yes, yes, we really hope you all will join us then. Our goal is we'll be, speaking both about kind of policy priorities for the diabetes advocacy community. We'll be hearing from experts at state policy to hear kind of what they expect coming down the pike. And we'll share our own thoughts and reflections on, what were the trends we saw in 2024 and what we expect to see going forward in 2025. So now as we are coming up on the hour, we'll need to stop there. My thanks to all of our speakers, as well as to everyone listening in today and our funders at Helmsley Charitable Trust for making all of this possible. I hope you enjoyed the conversation. Link to register for the next webinar is in the chat. And so we know there will be a lot of action to come, and hope you'll be able to join us. Thank you and have a great weekend all.